Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from AbbVie.
Hi, I'm Dr. Russ Cohen. I'm a professor of medicine, the clinical director of the Inflammatory Bowel Disease Center, and the co-director of the Digestive Diseases Center at the University of Chicago's Pritzker School of Medicine. Welcome to this Medscape program titled Debating New IBD Treatments. Ready, set, go. I'm very pleased. Joining me today is Dr. Anita Afzali, who is the James F. Headley Endowed Chair and a Professor of Medicine, as well as the Interim Chair of the Department of Internal Medicine at the University of Cincinnati College of Medicine in Ohio. Welcome, Anita.
Thank you, Russ.
I'm really excited to get into our discussion today. We're doing a quick fire format. We'll ask each other a question, and then we'll have just 60 to 90 seconds to respond, maybe time for a short rebuttal if we disagree on anything. But how could we disagree?
Never.
So let's get started.
Okay.
Anita, first question's to you. For a patient with ulcerative colitis who does not seem to be responding to an anti-TNF therapy, at what point do you decide it's time to move on to a second line therapy? Now you have 90 seconds.
All righty, Russ. So that's a great question. When I start with a patient who has ulcerative colitis on an anti-TNF agent, I look for early clinical improvement. And by early, I mean 2 to 4 weeks. And then I expect a maximal response by that 12 to 16 weeks. Now, despite careful dosing and monitoring, what we know, Russ, is that roughly a quarter of patients show a primary non response, and about one third of patients actually lose a response over time. So, if there's no meaningful clinical improvement by that 12 to 16-week mark, after confirming therapeutic drug monitoring and checking those levels and ruling out infection or other causes of symptoms, I consider at that point for the therapy to be a failure and it's time to move on to a second line option. And so, of course, I want to make sure that I get your impression of this, Russ. Let me ask you the exact same question. Is this approach same for yourself, or what are you doing in regards to that second line?
Yeah, well, Anita, you brought up many good points. I think, the issues are make sure the patient isn't infected, make sure they don't have C. diff. You can make sure they don't have CMV. Sometimes people may have clinical symptoms that improve or don't improve that may be out of sync with their objective measurements of inflammation, perhaps a fecal calprotectin, or even looking in with a sigmoidoscope in an ulcerative colitis too. But we really like to see people progressing, as you mentioned, responding within the first few weeks and then continue to respond, if not go into remission moving forward. I think that at some point, then you have to just say, well, it's helpful to clarify with TNFs of whether the patient initially responded to that loading dose and then seemed to do less well, or did they not respond at all? For the people who never responded to the loading dose and aren't infected, I think it's time to move on if they're not getting better after the subsequent doses. But for people who did get better initially with the loading dose, with the anti-TNFs, you actually just may need to get a higher dose, especially in infliximab, where we have the range of dosing from 5 to 10 milligrams, more frequently from every 8 weeks to 6 weeks to 4 weeks, or in adalimumab or the other injectables, either a higher dose or giving it more frequently as well too. So it's helpful to differentiate whether, hey, the TNF pathway is working, it's just I need more drug, or this isn't really the way to go. And that'll help you decide upon where do you go next.
So, Russ, let's dig a little deeper into what you're saying as far as transitioning into that second line treatment. What factors do you consider when you are deciding among the choices for the second line therapy in IBD? And really, what are you prioritizing as a first or second consideration or factor?
Well, I think it's very important, and a lot of people may not spend enough time doing this. So, first, like I said, did they get better with the induction? Were they initially well, and then did they lose response? Sometimes, if you're moving on, even with the initial therapy choice or moving on to the next one, there are options now that are IV, that are subcutaneous injections, self injections, that are combination or oral agents. What would the patient prefer to do, or what might work better for them with their insurance, with their living situation, whether it's school, whatever it may be? How soon does something have to onset? I think also it's important to know that we have good evidence suggesting that if patients never responded to an anti TNF, then usually we would turn to a therapy such as an anti 12/23, an anti 23, or a JAK inhibitor rather than going to an anti integrin or an S1P modulator, just because those therapies didn't have great data in patients who had failed anti TNFs. Of course, you also want to consider what are the safety issues for that particular patient, whether they've had history of cardiovascular disease, blood clots, infections. I'm in the Ohio River Valley, so histoplasmosis, patients are exposed to that. We probably wouldn't go with TNFs or maybe not even JAKs and things like that. And then also, what are their pregnancy plans? So, Anita, let's throw it back to you. Are there any situations where you might try switching from the initial TNF to a second TNF as second line therapy? How would you decide to do that?
So I think it's going to be extremely important to first make that distinction between a secondary loss of response as compared to that primary non-response. So if a patient initially responded and then lost the response, that's that secondary failure that we talk about. Quite often do well with that second anti-TNF agent as compared to that primary non-responder. Primary non-responder, they're not going to very unlikely do well with another anti-TNF, so I would recommend changing the mechanism of action in that scenario. Now, before I make any of these decisions, it's really important for that therapeutic drug monitoring. Do we have the right drug trough concentration? Are we dealing with antibodies? And based off of drug level as well as antibodies, that's how I determine. For example, if the drug level is low and there's no antibodies, I'll first try dose optimization as compared to if there's high antibodies with low drug levels, then at that point, what we call that immune mediated loss of response. And that makes me more confident that it's time to switch to another anti-TNF in that situation. So really all of this hinges on why the anti-TNF fail. Primary, secondary response, or loss of response, and then of course the therapeutic drug monitoring.
Okay, well, I think that's a fantastic, thorough answer, and I actually would agree with the same. So let's switch gears a bit. We're moving on to non TNF therapies. I have a television at home. I see all these commercials. There's so many treatment options now for ulcerative colitis and Crohn's disease after TNF loss or even naive. So what are we looking at now? The FDA approved therapies for these moderate severe Crohn's and UC patients.
Yeah, so after a patient with UC, Crohn's disease loses that response or can't tolerate an anti-TNF, we have several highly effective and safe second line options. So for both UC and Crohn's, I would consider the IL-12/23 inhibitors such as ustekinumab. We have our P19 inhibitors or the IL-23 inhibitors such as risankizumab, gazilumab. We have our JAK inhibitors. This is, for example, tofacitinib or upadacitinib. And then, of course, we have our anti-integrin, such as vedolizumab, as well as that S1P modulators, such as etrasimod or ozanimod. So for ulcerative colitis, that those S1P modulators are the ones that we would consider in that situation. And then, of course, with the JAK inhibitors, upadacitinib in that situation is available for both ulcerative colitis as well as Crohn's disease.
Right, and also mirikizumab is the third of the anti-P19 IL-23s that we can use for either too. So we have a lots of options, which is a lot better than it used to be for us. So you gave me the list, Anita. How are you going to decide what to use? What do you start? What do you do? 90 seconds. Tell me.
Well, my starting point is always shared decision making. It's going to be incredibly important to look at disease factors, patient related factors, safety considerations. All of these are factors that we need to look at in totality through shared decision making. This is also when I'm looking at the disease phenotype. How severe is it? What's that burden of inflammation? And then again, that phenotype, is it fistulizing? Is it stricturing? Are there presence of extraintestinal manifestations? And in that situation, I would actually, for example, think of a JAK inhibitor or maybe our P19 inhibitors if there's the gut and the skin involvement. When I weigh in the patient related factors, I look at medical comorbidities. I look at determining based off of those medical comorbidities, are there higher risks accordingly based off of underlying other disease states? Are they women of childbearing age? What's your route of preference? That's where shared decision making comes in. And then from a safety and monitoring, I'm looking for, again, based off of medical comorbidities and disease and patient related factors, I need to find a treatment that's effective, but I also don't want our patient or us to balance or weigh or exchange safety for efficacy. So we need to find the right treatment for the right patient at the right time. So these are a few factors that I take into consideration when I'm thinking of what's next for our patients. But Russ, let me bring this back to you now. How do you prioritize among all of these options I just shared? And is your approach, which shouldn't be, but is your approach different from mine?
Anita, that was a fantastic summary because the point is what you said. Who is sitting in front of you? Who is coming in through that door? What have they been on before? What are their risks? What are their benefits? What do they want to do? Shared decision making is, especially if you have multiple options, maybe see, because you'll be surprised. The patient who you think might want to take one pill a day actually may would prefer to have an IV 026 every 8 weeks by a medical professional. Or maybe they travel extensively and they want a sub Q that they take every 2 months. So if letting the patient decide along with you, in my mind, makes this a decision that we made together rather than a decision that I made for the patient. And I think that's important. Our patients are often very educated, they're very up on things. And they're often younger than most internal medicine patients too. And they're gonna check up on you. So I think it's helpful for them to be involved in that whole decision process.
That's well stated, Russ. Quick follow up. How does the mechanism of action factor weigh into your treatment decisions aside from shared decision making?
So this is a good question, Nita. So I think it's very clear for us that if patients have perianal Crohn's disease, most of us still are going to lead with an anti-TNF. There is some data with some of the other agents, but still that's pretty much the way to go. That mechanism seems to be the one. On the other hand, patients who seem to have clearance of the monoclonal antibodies, let's say ulcerative colitis, they got their infliximab, they got it, it's IV. Yet when you check the level, the drug level is non-existent and there's no antibodies. Where did the drug go? These patients may be clearing these monoclonals through the reticuloendothelial system or some other process. So that might be someone who will go to a small molecule. In University of Chicago, we used to go to tacrolimus or oral cyclosporin, but now we have the JAK inhibitors and the S1P modulators or oral agents where you don't have to worry about the clearance. So I think that the mechanisms, and then the final part would be if they have another condition, rheumatoid arthritis, psoriasis, psoriatic arthritis, ankylosing spondylitis, et cetera, where you could, get two birds with one stone. So, Anita, as you well know, we have new guidelines from both the American College of Gastroenterology and the American Gastroenterological Association. So, which guidelines do you look at? And do you rely on them?
I definitely do. I rely heavily on both the AGA as well as the ACG guidelines, and I use them a bit differently. So, with the AGA guidelines, remember these were the guidelines that sort of put a bucket by efficacy type of approach. And so here they compared head to head, being able to bring in and rank from head to head studies, rank these in order as far as high, intermediate, or lower efficacy, which really is helpful when we're mapping out options and having those treatment considerations for our patients. The ACG guidelines, which I will say that has been updated in 2025, and I'm very happy and proud to have been a part of that group, it takes a more broader view and perspective. It's based off of the strong evidence-based recommendations, but it also it has a little twist to it where how can we tailor this through shared decision making to be more individualized with patient specific factors as well. Of course, taking into account efficacy, but it doesn't have that bucket of efficacy. I think both the ACG as well as the AGA guidelines should be just that, guidelines, recommendations to help set that initial framework for conversation that we should all be having with our patients. Now, Russ, 60 seconds, your response. What's your take of the guidelines?
Sure. Well, I think the guidelines are helpful in that they really bring home some important concepts. The first one is that corticosteroids are not good. You might have to use them once, maybe twice, but we really have to move away from using steroids, hopefully at all. Number two is top down approaches. Anything that's FDA approved for moderate severe ulcerative colitis or moderate severe Crohn's disease should be used in patients with moderate severe disease. Moderate means you look at it in the scope and you see ulcerations, you have at least moderately severe disease. So don't waste your time on therapies or the patient's time and continued sickness with ineffective therapies. Get right on these very safe and effective therapies. And the third principle is called treat to target. Your target in ulcerative colitis is the lining of the colon looks normal. Even under the microscope, that'd be great if it was normal. You may not get there instantly, but make sure you're getting there. And if you're not getting there, do something. With Crohn's disease, it can also be endoscopic, but perhaps through some three transmural imaging with a CAT scan, MRI, or maybe now intestinal ultrasound. But prove whatever you and the patient chose is doing is working. And if it's not working, do something about it. Increase the dose, add another therapy, switch mechanisms, consider surgery.
I love that. Russ, I'm going to, in the few minutes we have left, let's talk about safety and monitoring. We've kind of alluded to this as well. So let's focus on our JAK inhibitors as well as the IL-12/23 inhibitors. What kind of monitoring, lab monitoring, or other types of monitoring do you do in patients before starting a JAK inhibitor? And then while they're also on active treatment with these medications?
For all these therapies, before you start, you have to do a TB test and hepatitis B. Make sure they don't have that. If you don't do it, the insurance won't approve it. So just do it. Okay. Patients should have a CBC with differential, a comprehensive metabolic panel, or hepatic function panel. We like to chew a C reactive protein. You can do a fecal calprotectin if you want. With the JAK inhibitors, you check a lipid panel. Subsequently, you're monitoring a month later, and then every 3 to 4 months should be a repeat of the CBC with diff, hepatic function panel. The lipid panel, at least once you should repeat on the JAK inhibitors. It's real unclear after that too. But other than that, the monitoring is also not just the labs, but you should be seeing this patient, or your advanced practice provider should be seeing them either in front of you or through video. And you have to ask the patients not only how they're doing, but what else is going on. Because they may not know to tell you that they've been diagnosed with another condition, perhaps a tumor, perhaps a skin condition, maybe got psoriasis on a TNF. They may not know to tell you. So make sure that you are seeing that patient every 3 to 4 months and monitoring them, especially with the JAK inhibitors, the TNFs, and the S1Ps, because they need more careful monitoring. The others, perhaps every 6 months once they're well.
All right, Russ, any medical conditions that you would keep from that would keep you from prescribing a JAK inhibitor?
Well, we generally are a little cautious in JAK inhibitors in people who are elderly, who have active infections, who have active cardiovascular disease, who have had or have venous thrombosis, although it doesn't mean you can't use them, but probably not your first choice. We don't use JAK inhibitors in pregnancy, at least initially in pregnancy. That's probably a little more nuanced answer than we can go through right now. Okay, so Anita, we talked about that. What about the IL-23s? Is there anything you're concerned about in those patients?
I think with the IL-23s and still as we talk about different mechanisms and different options, overall we want to ensure that we treat these medications appropriately with the same level of monitoring that you described, whether it's our JAKs or not. Overall, we want to ensure we avoid live vaccines. We get all the pre-testing. We want to make sure our patients are up to date with immunizations. Hypersensitivity reactions is rare, Russ, but that is something we need to also monitor and be mindful of for. So, aside from what we typically do with all meds, there isn't anything in addition that I typically do with the P19s or the IL-12/23.
Terrific. Well, Anita, our time together has come to an end. Of course, you did a fantastic job as always, and thank you for joining me in this expert quickfire. And thank you, the audience, for participating in this activity. I hope you found this format to be engaging and interesting. And please continue on to answer the questions that follow and complete the evaluation so that Anita and I can invite it back another day. Thank you so much for joining us.